He did keynote last year.
Such a beautiful spring break Friday. I want to welcome all of you who are here today. We've got a very special Grand Rounds that I think everyone is going to go away very new things. We're going to be discovering new things around it. So I just had a couple of announcements. We are definitely going to have a Grand Rounds next month. That's April 26th. And our own David Patrick is going to be presenting on some very cutting-edge results that they are recently getting. So you'll definitely want to come to that. So I will introduce today's rounds. We have a special guest, Stuart Kinner, who is a Peter Wall International Visiting Scholar at the moment, and is from Melbourne, Australia. Stuart is the head of the Justice Health Units at University of Melbourne and the Murdoch Children's Research Institute. The research focuses on the health of adolescents and adults who have contact with the criminal justice system. Now, he also chairs several important committees, and he only just flew in from Las Vegas from one of those meetings. And so forgive him if he seems a little jet lagged. He is also a part of the steering committee of Worldwide Health Prison Research Engagement Network and WHO Steering Group, Patients' Health, and the Health Team in the UN Global Study on Children's Deprivation of Liberty. So it's going to be pretty exciting. Now, those of you who came expecting to see Jesse Young, unfortunately, he's still in Las Vegas. So not going to go any further than that. You can make up the story on your own. And we will, though, introduce Ruth, our own Ruth. And she's going to be introducing the overall concept and is concepts to get us aligned on transformative health justice, and will be setting the stage for us. So the title today is Improving the Health of People Exposed to the Criminal Justice System, a Global Health Priority. And with that, I invite Ruth.
Thank you very much. And Stephanie, can you help me move? Do I just move this down to one of my slides? Okay. Oh, so my slides are attached onto here. Okay, so this is, everybody should know about the evaluation form. So I'd like to acknowledge that our place at work is within the ancestral, traditional, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So good morning, and thank you for coming to Grand Rounds this morning. And over the next 60 minutes, we aim to make a case for why improving the health of people exposed to the criminal justice system is a global health priority. So I'm going to just talk a little bit about CCPHE, Collaborating Centre for Prison Health and Education. So this started in 2006 with our first meeting in the basement of IRC. Some of you were at that meeting, namely Jane Buxton, I think. And we were inspired by the Health in Prison project of the WHO Europe. And we invited members of correctional organisations, members of non-profit organisations, health organisations, and academic faculty to collaborate together to work towards enhancing the health and well-being of individuals who've been experiencing incarceration and or were being reintegrated. And since 2006, for the last 13 years, we have encouraged and facilitated opportunities for research, health education, and knowledge exchange. And our definition of health encompasses physical, emotional, social, and spiritual, as illustrated by the iceberg. So you can, obviously, you're welcome to go to the webpage and learn more about us, but I just wanted to highlight 2 current projects that we're engaged in that we're feeling quite excited about. So the first is this UBC Grants for Catalyzing Research Emerging Clusters, and it was awarded in January, and we called it Transformative Health and Justice Research. And the grand challenge that we seek to address is the criminal-centric understanding of crime, rehabilitation, and recidivism. So we aim to create a research agenda to reframe the criminal justice system as an opportunity to address health and justice inequities for peoples by focusing on 3 interrelated research themes. So determinants of health and justice, incarceration, and reintegration. And we aim to collaborate across disciplines. So I co-lead the cluster grant with Dr. Helen Brown, who's faculty of the School of Nursing. But we also have, as you can see, some faculty from SPPH. So Chris and Jane are here. I don't know if anybody else is here. Oh, Leanne Donnelly from Dentistry, faculty from Law, including some Indigenous scholars, and Psychiatry, Medicine, Education. And so we're guided by the principles of community-based participatory research. And accordingly, our first activity was our community advisory network, which met for the first time last week. And we wanted to focus on our research theme, the determinants of health and justice. And the network includes an appointed Indigenous elder and people with lived incarceration experience, and members of Elizabeth Fry Society, John Howard Society, CSC, BC Corrections Branch, PHSA, First Nations Health Authority. And in that time, as we focused on the determinants of health and justice and shared our experiences, we also then did an appreciative inquiry exercise where we dreamed of what could be possible for the future. And this is the wordle that kind of came out of that work. You can see the most prominent themes were understanding family, community, healing, etc. So the second thing that I wanted to talk to you about, or tell you about, was that we did receive some Peter Wall Institute for Advanced Studies funding, which will bring together interdisciplinary scholars and community and correctional leaders, artists, policymakers, and individuals with incarceration experience, including delegates from Europe, US, Brazil, Haiti, Canada, and Australia, to explore solutions to the vast systemic health justice issues that are faced by individuals with incarceration experience. And we will have a public event on the evening of April the 25th. The invitation flyer will be going out on Monday, and we'd love to see you at that event. It'll be at 5:30 to 7:30 in the Queen Elizabeth Salon. So that we're really looking forward to that opportunity to dig deep into the global challenges. So in addition, we also received Peter Wall funding. We're delighted to have Professor Stuart Kinner with us as an international visiting scholar for 4 months. I hope you'll all get a chance to meet him and get to know him, and thank you for coming this morning to listen to what he has to say. So thank you very much. Over to Stuart.
Thanks, Ruth, and thanks for the opportunity to come and speak with you. I need to change that profile picture. You know, more hair and fewer wrinkles when that was taken. I'm going to look it for as long as I can. Ruth has sort of set the stage for the presentation today. And I guess I thought about what is it that I want to do, and I'm going to share with you some of the research that we've been doing in Australia, just to give you a sense of some of the health issues for people who experience incarceration. But I suppose that's not the primary purpose. That's a bit sort of show and tell. I guess what I want to do is, if you may not be persuading, but if you do, hopefully you'll come away from this seminar convinced that addressing the health needs of people who experience incarceration is not a niche issue. It's not some kind of weird thing that a couple of people over in the corner do. That it's actually an important part of a health equity agenda. It's part of addressing health inequalities at the population level, and therefore also at the global level. And that ties back to the WHO work that Ruth's referenced. And I'll speak a bit more about today. I just want to acknowledge the funding. In Australia, we have the NHMRC, very much like your CIHR, and we've been very fortunate to get quite a bit of funding from them to support some of the work that we're doing, and a little bit from our SHRC, the Australian Research Council. So I think that that's one of the things that we need to make sure that we're doing, is continuing to seek substantial funding for quality research in this area. I've heard a wonderful phrase to describe the lack of investment in quality research in this area, this idea of the soft bigotry of low expectations, that research that's not the best quality research is perhaps good enough in this area. And so I put to you quite strongly that that's not the case, that people who experience incarceration deserve the same top quality research that characterises other areas of health research. So just setting the scene, this is a fairly famous person who's experienced incarceration. You may have heard of him, Nelson Mandela, and I'm sure you've probably seen this quote before as well. No one truly knows a nation until one's been inside its jails. A nation should not be judged by how it treats its highest citizens, but its lowest ones. You might not want to think of people who experience incarceration as the lowest citizens, but you get the idea. So the United Nations has for a long time had some standard minimum rules for the treatment of prisoners, and those were updated and expanded in 2015 and renamed the Mandela rules, obviously in honour of Nelson Mandela. And I just want to draw your attention to a couple of those rules that are particularly relevant to what we're talking about today. So Rule 24.1, which is typically described as the principle of equivalence. So it says prisoners should enjoy the same standards of healthcare that are available in the community, and should have access to necessary healthcare without discrimination on the grounds of their legal status. So the principle of equivalence. It's been put previously by Alexander Patterson this way, that people are sent to prison as punishment, not for punishment. So in other words, we shouldn't be in any way punishing people through deprivation of healthcare, or in any way compromising the quality of healthcare that they receive. So that's the principle of equivalence. The other rule I just wanted to draw your attention to is Rule 24.2, which is all about continuity of care, and pointing out that we should be thinking about delivering healthcare in prisons in a way that is closely aligned with what we do in the community. For the obvious reason that almost everybody who experiences incarceration returns to the community. So we're not talking about a separate population of people. In fact, it's probably unhelpful to start talking about a population of prisoners. It's a population of people who experience incarceration in the same way as people experience moving through other large state-funded institutions, hospitals, schools, etc., etc. It's an institution through which people move. It's not a population of people called prisoners. So just to set the scene again on the scale of the issue that we're talking about, here's the most recent global data on incarceration rates around the world. Australia and Canada are both in the middle-ish. We're a little higher than you guys at the moment, but neither of us is at the very bottom end or at the very top end of that incarceration distribution. We're all in the middle. Ooh, what's going on there? Wow, that's cool. So we know that there's about 11 million people in prison around the world on any given day at the moment. We actually don't know how many young people are detained in youth justice facilities. There's not even a global estimate of that. In 2008, UNICEF estimated 1.1 million, but it's a little bit back of an envelope, so we really don't know. But the other point is that that's the stock, if you can forgive the phrases, we need to think about the flow. How many people are moving through these institutions? Because in many parts of the world, people spend a relatively short period of time in custody before they return to the community. So another very back of the envelope estimate from the UNODC in 2008 is that about 30 million people move through prisons each year. So we're talking about a very substantial number of people globally exposed to this system. So it's really important to think, what's the implications of that for health and for health inequalities? So what do we know about the health of people who experience incarceration? We know a lot more about some health issues than others. Perhaps one of the things we know the most about is HIV. So we know that the prevalence of HIV is considerably higher among people in prison than among people in the community. Nevertheless, you can see this is a paper in the Lancet by Kate Dolan recently looking at the prevalence of HIV in prisons around the world. You can see that it varies enormously. I mean, I'm not going to go into the details of what country is where. The point, though, is that the prevalence of HIV is amplified in prisons compared to the communities in which those prisons sit. So whatever the prevalence is in the community, you can be sure that that prevalence is higher among people who've come from that community into prisons. So there's a concentration of ill health in prisons. And that's true equally when we start thinking about hepatitis C. In Australia, there's about a third of people in prison who are antibody positive. And it's also just as true when we start looking at tuberculosis. And of course, HIV, TB, co-infection is a big issue in prisons as well. And the issue is then, what do we do once people are in prison? You know, we have people in this highly structured setting where they have very restricted control over their own health, and where the state has very increased duty of care to look after the health of people. Here's some work by Rajan and others in Epi Reviews last year, looking at the prevalence of bloodborne virus and STI risk behaviours in prison. You can see they're looking at injection drug use, risky sex and tattooing in prison by WHO region. And so again, the point is that it's enormously variable. And it's not the case that one solution will fit all, but it is the case that particularly given the high prevalence of communicable diseases in prisons, it's really important to get it right in terms of responding to these health risk behaviours in prison settings. You know, it's been described somewhat pejoratively that prisons are a disease pump, that we concentrate people with communicable diseases in those settings, and if we don't do the right thing, we're amplifying the prevalence and sending that back out into the community. So this is just a really clear illustration of why getting prison health right is part of public health and part of addressing health inequalities. Just to give you one example of that, here's some work we did in Australia where we were lucky enough to do a fairly large survey of people who were incarcerated, and not only were we able to do a survey of a representative sample of people who were incarcerated, we were able to use unit record correctional data at the state level to come up with some very robust estimates of state level, province level, prevalence of various health issues and health behaviours. So here we're looking at injection drug use, and so we've set some fairly tight confidence intervals. We were able to say, okay, in the state of Queensland, where we did this study, 55% of people who experience incarceration have a history of injecting drug use. 23%, nearly 1 in 4, has a lifetime history of injecting drug use in prison, and around 1 in 8 had injected in prison during their current episode of incarceration. So this is in a context where 1 in 3 people in prison is hepatitis C antibody positive. We don't know for sure how many people have chronic infection. So clearly very, very important to respond appropriately to the risks of communicable disease. And of course, it's not only the case that we concentrate people in prison who have infections and who engage in risk behaviours, but it's also the case that among those people, the people who continue to engage in those risk behaviours are probably the people you'd least like to see doing that. So in that same study, we asked the question, among people with a lifetime history of injecting drug use, who continues to inject in prison and who doesn't? And what we found is that the people who continue to inject in prison are very considerably more likely to have a history of sharing injecting equipment, much more likely to have received a tattoo during their current prison sentence. And you're probably aware that there's nowhere in the world at the moment, almost, where you can get safe tattoos in prison. So there's a vector for transmission of infection outside of people who inject drugs in prison as well. More likely to be male, poly-drug users, hepatitis C exposed. So in other words, the people who you see continuing to engage in risk behaviours in prison are the people you'd least like to see doing so. So this is really an important illustration of the importance of evidence-based harm reduction measures in prison settings. So I don't want to dwell on the hand-wringing epidemiology of the health issues for people in prison. So trying to summarise the entire literature in one slide, we know that entrenched intergenerational disadvantage is something that distinguishes people who experience incarceration. People who are in prison are much more likely to have experienced the incarceration of a parent. In Australia, for example, 1 in 5 Indigenous children experiences the incarceration of a parent. It's extremely common. And we know that there's a very high prevalence of syndemic health problems, so health problems in epidemic proportions that interact in a synergistic fashion. So very high prevalence of mental illness, and often with co-occurring substance use issues. A very high prevalence of infectious diseases, but also, and this receives less attention, a very high prevalence of non-communicable diseases as well, asthma, for example, and a very high prevalence of cognitive disabilities as well as physical disabilities and acquired brain injuries that have really important implications for people's behaviour and their capacity to manage their own health needs in their lives after they return to the community. So complex morbidity is normative, and so a lot of the literature in this area talks about one health condition. So you get research looking at HIV, or research looking at psychotic illness, or research looking at opioid use disorder, and that's fine and that's important. But one of the things that's perhaps not focused on enough is that complex co-occurring health conditions are normative in people who experience incarceration. That's important because, therefore, effective responses to those health needs are necessarily multidisciplinary. And we probably don't do nearly as well, we don't do as well as we could in that area in the community, and the importance of getting that right is amplified in prison settings given the high prevalence of multimorbidity. So here's some work by Stephen Dent, who had a look at a very large sample of people in prison and asked the question, well, what are some of the health conditions they have? So he coded some prison medical records for around 1,300 people using a thing called the Cumulative Illness Rating Scale, which is a way of characterising multimorbidity in primary care settings. And so basically what it's showing is the prevalence of each of these different categories of health conditions and the severity of those health conditions separately for men and women and for Indigenous and non-Indigenous people. And again, I don't want to get lost in the weeds looking at the detail of this. Very happy to share these slides for anyone who's interested. But it's just to illustrate that there's quite a high prevalence of a number of health conditions in these people. It's not just psychiatric issues, not just respiratory issues, which are one of the things that we probably don't talk about enough in this population. And as I said, the co-occurrence of those health issues is normative. So again, in this sample, 28% of this group of people, a representative sample of people in prison, had at least one chronic physical health condition, at least one diagnosed mental illness, and at least one significant substance use issue. So more than 1 in 4. So that complexity is extremely common and necessitates high-level coordinated care and case management, not just while people are in prison, but also after they return to the community. So stepping back a little bit and thinking about what this means in terms of health inequalities, Ruth mentioned before the WHO Europe Health in Prison program that's really been leading the way in thinking about policy reform and governance in this area. This is the second edition of their excellent manual on how to think about and deliver healthcare in prison settings based on the available evidence. So trying to summarise a very rich resource in one slide again, I think a few of the key issues, they're pointing out that there's a real regrettable public health opportunity, but an opportunity nevertheless to implement routine screening and assessment for people who experience incarceration. That's important because we know that people who experience incarceration tend to underutilise primary and preventive care in the community. And so this is unfortunately the first time for some people that they ever have the opportunity to have their health needs identified and addressed. So it's an important opportunity. Even better if we could address that in the community without having to incarcerate people, but nevertheless it's important. So there's opportunities for initiation of treatment for people who have health issues identified when they're incarcerated. The word initiation is important because if we're going to genuinely change people's health trajectories, it's not just about what we do while they're incarcerated, it's about sustaining those treatment regimes after people return to the community. And that's something that you'll see in a moment we don't do nearly as well as we should. So one of the things that distinguishes healthcare in prison settings is that it's low threshold. One of the reasons that people in the community who experience incarceration underutilise healthcare is because of the barriers. There's enormous barriers. There's structural barriers, there's stigma barriers, there's cost barriers, there's racism barriers, numerous barriers to access and care. Those thresholds for care access are lower in prison. So again, it's an opportunity to try to engage people in treatment, at least to initiate that treatment. And higher intensity, and so that's important to this notion of equivalence that we spoke about before. Equivalence doesn't mean the same. Equivalence means achieving the same outcomes. And to achieve the same outcomes with a population with significant health needs, you need a higher level of inputs. So we need to invest disproportionately in prison healthcare to achieve the same outcomes. Getting back to Rule 24.2 of the Mandela Rules, one of the key things about effective prison healthcare is that there's partnerships with community health providers. So no matter what we do for people in prison to improve their health, if we want to change their trajectories, we need to sustain that after people return to the community. And that's all about partnering with adequately funded community health partners who are supported to engage with people while they're still incarcerated. The other thing that's emerging as an area of interest is this idea of education and engagement with correctional officers. So it's still the case that the vast majority of the budget that goes into prison settings is for incarceration, not for healthcare for people who experience incarceration. And so correctional officers are potentially an important resource for health promotion, for identification of health needs. So there's a move underway, very early days, to really start exploring culture change within corrections, to have corrections and correctional officers active partners in health promotion and in achieving health equality. The other thing from a governance perspective that WHO has been useful in thinking about is how we deliver healthcare, not from a clinical perspective, but from a governance and policy perspective. So WHO and the UNODC published about 6 years ago now this report on what they call good prison health governance, and it's very relevant to BC at the moment. A few of the things that they point out about that would distinguish good governance in prison healthcare is that there's a duty of care, there's a recognition that the duty of care for people in prison is very high. When people are deprived of their liberty, there's a very high level of onus on the state to appropriately care for their health-related needs. And this idea of equivalence again. Critically, this idea that healthcare can't be used to punish people. So no matter what people do, no matter what happens while they're in prison, that should have no impact on the healthcare that they receive. It seems obvious, but it's important to articulate. This idea that healthy prisons means healthy prisoners and eventually healthy people, not just people in prison. And they point out that it's a whole of government responsibility, and critically, and this is perhaps the key thing in this document, WHO argues strongly that healthcare in prison should be organised and run by the Ministry of Health, not by the Ministry of Corrections or the Ministry of Justice. The reason being that there's a potential role conflict, simultaneously punishing and providing healthcare. The other key reason why that's thought to be important is because it facilitates continuity of care. Because obviously the Ministry of Health is going to be responsible for people's health needs once they return to the community. So thinking back to Rule 24.2 of the Mandela Rules, one way to maximise continuity of care is to have the same ministry responsible for healthcare in prison and in the community. So you're probably aware in BC that transition occurred in October 2017. So now the Ministry of Health is responsible for healthcare in BC prisons. So there's an important opportunity here to understand what that has meant for people in BC who experience incarceration. A third document that the WHO has published, and this is also in its second edition now, is a document that summarises what we know about preventing overdose among people who have contact with the criminal justice system. Why does that matter? Because we know that people who experience incarceration are at dramatically increased risk of overdose, and that's again obviously highly relevant in the BC context given the current overdose crisis. But I just want to drill into that a little bit more. There's actually been quite a few studies around the world now demonstrating this phenomenon. These are some data that we produced from Queensland and Australia, where we linked correctional records for about 42,000 people with their National Death Index. And we asked the question, how many people die after release from prison? By a week after release from prison. So you can see this enormous spike in deaths immediately after release from prison. This is unfortunately a highly predictable phenomenon now. It's been demonstrated in many different parts of the world. There's been 3 meta-analyses in this literature now. It's unfortunately well documented. So we can see that there's an enormous spike, and that's what WHO has been focusing on, saying, let's reduce these deaths. What are these deaths due to? Disproportionately alcohol and other drug-related. Typically in that first week we're talking about opioid overdoses. So that's really, really important because there is an acute spike in drug-related deaths just after release. But what I want to draw your attention to is this. So the number of deaths in subsequent weeks is lower, but if you add all of those up, it's a lot higher than this bar in the first week. So if our interest is in minimising deaths in people who experience incarceration, we most definitely shouldn't just focus on the period immediately after release. It is a period of acutely elevated risk, but most of the preventable deaths in this population happen after those few weeks, and that's something the WHO hasn't really recognised quite enough yet. Just to illustrate that a little bit more, here's some work by Matt Spittle doing some secondary analysis of those data, and what it's looking at is the rate of drug-related death after release from prison by time, and the rate of suicide death after release from prison by time. So you can see in the first 2 weeks after release from prison, there's this acute spike in the rate of drug-related death, and there's no comparable spike in the rate of suicide death, at least in our study. So that would tend, and that's what's led to people saying, well, let's focus on preventing drug-related deaths, that's super important, that's where the spike is. But what I want to draw your attention to is this. If you look over the longer term, and we followed people for up to 15 years in this study, the rate of drug-related death and the rate of suicide death over the longer term is almost the same. So what does that mean? If we're focusing on preventing acute deaths immediately after release from incarceration, overdose is a key cause. If we're also interested in minimising deaths in people who experience incarceration in the longer term, we need to think at least as much about suicide prevention, about mental illness, and about all the other drivers of suicidal behaviour. So it's not just about overdose. And again, just to illustrate the point here, although there is an acute spike in deaths, things don't get better in the long term. So here what we're looking at is the estimated rate of death or survival in the population of people in Queensland of the same age and sex. So this is what we would expect in terms of survival, and here's what we observed in terms of survival after release from prison in this particular study. So over the long term, up to 15 years, the rate of mortality in this population is more than 3 times that of their age and sex matched community peers. So that's not all caused by incarceration by any means. People who experience incarceration enter the system already characterised by many risk factors for early and preventable death, and we're evidently not doing nearly as much as we could to change those trajectories. I'm not going to focus much on youth justice just because we don't have a lot of research, but I just want to quickly share some findings from a study that we're doing in Queensland at the moment. This is really the first ever study to look at mortality in young people who've been through the youth justice system. So I mentioned before, there's now about 30 studies around the world that have looked at deaths in adults released from prison, but almost nobody has looked at deaths in young people who've been through the youth justice system. So here we've linked records for about 49,000 young people who had contact with the youth justice system in Queensland and Australia. And what we're looking at is this, the all-cause standardised mortality ratio. So how much is the risk of death by any cause elevated in these young people compared to their age and sex-matched community peers? And you can see that it's enormously elevated. It's enormously elevated, particularly for Indigenous girls, and for non-Indigenous girls also quite dramatically elevated. In fact, across this whole sample, the rate of death there is also a little more than 3 times above their age and sex-matched peers. So young people who've been through the youth justice system are also at an enormously increased risk of preventable death. And I don't think we've even started thinking about that enough, never mind thinking about how we prevent that. We are also interested in penetration into the youth justice system. So in this study, unlike the study that I showed you before about people who've been in prison, here we're looking at all young people who had any contact with the youth justice system. So of those 49,000 odd people, only about 8,000 of them were actually ever detained. The rest were either serving a community-based order, so supervision in the community, or they'd been charged with a crime as an adolescent, but never convicted of anything. So this is relevant to thinking about what we do. So here we're looking at all-cause survival for young people who were charged with a crime but never convicted, young people who only ever served a community-based order, and young people who experienced detention. So there's a clear dose-response relationship between penetration into the youth justice system and all-cause mortality risk. And again, I'm not saying that that's causal. There may be a causal component, but we don't know. But we know that there's a concentration of risk in young people, particularly those who experience detention. And again, clearly we're not doing nearly as much as we should to change those trajectories. What are they dying from? In this study, suicide is the leading cause, so about 1 in 3 deaths in these young people. Nearly all of these deaths happen before the age of 25. Nearly 1 in 3 of them was a suicide death. For Indigenous girls, 38% of them were suicide deaths. So clearly we need to be thinking a lot more about prevention, not just about delivering healthcare and attention, but improving long-term health-related trajectories for all young people who have contact with the youth justice system. Just quickly before I get to the discussion part of today, I just want to share a few of the findings that we've generated about the people who don't die after release from prison. Until probably 10 years ago, really, unfortunately, the only things we knew about people released from prison is that a disproportionate number die and that most come back, which is pretty tragic. More recently, we started looking at what happens to the majority of people, what happens in terms of their health outcomes and their contact with health services. Here's some work by Rebecca Winter looking at relapse to injecting drug use. So what she did is look at people who had a history of injecting drug use before they were incarcerated. And the question is, what proportion of those people return to injecting drug use within a few months of release from prison? So what she found is that over a median follow-up of 98 days, 41% of those people had returned to injecting drug use. So it kind of belies the notion that we're correcting or rehabilitating. That this is obviously an underestimate because we lost some people to follow up as well. So a very large proportion of people with a history of injecting drug use rapidly relapse to injecting after release from prison. Again, evidence that we're not really changing trajectories. So incarceration is perhaps better conceived of as an interruption at best in health risk behaviour. Also interesting, what are the factors associated with relapse to injecting after release from prison? People who inject drugs in prison, and again that really underscores the importance of providing opiate substitution treatment for people incarcerated. We know that's very important. People who spend short periods of time in prison, so people who are churning through the system rapidly, are much more likely to relapse to injecting after release from prison. Again, suggesting that perhaps incarcerating people for very short sentences is not a great idea. People who are unemployed, which makes sense. Interestingly, in this study, parole was protective, so people who were released from prison on parole were less likely to relapse to injecting, although it turns out that that's a very time-limited protective factor. As soon as people are not on parole, they end up relapsing anyway. So again, it comes to this question of, well, are we trying to change people's long-term health trajectories, or are we just supervising and monitoring people for a period of time? What is it that we're actually trying to achieve? Some work by Claire Keane that's under review now, also looking at non-fatal overdose. We talked before about this spike in fatal overdose deaths after release from prison. We know, of course, that for every fatal overdose, there's probably 20 non-fatal overdoses, again, very relevant in the BC context. So this is some work where we looked at, in blue, the incidence of opioid overdose, and in red, the incidence of overdose of any substance by time after release from prison. So we did this by prospective linkage with ambulance, emergency department and hospital records for about 1,300 people. And what you can see there is there's a very distinct spike in non-fatal overdose after release from prison. And one of the things that's perhaps forgotten about when we talk about non-fatal overdose is that non-fatal doesn't mean it's okay. There's a lot of long-term morbidity associated with non-fatal overdose, notably including acquired brain injury. Some work by Jesse Young that he would have shared with you himself if he'd been able to make the plane. Unfortunately, he wasn't able to be here today. We published in Last Public Health late last year, is looking at injury after release from prison. And there's a bit of detail in this figure, but I just want to take you through it. So here, what we're looking at is the incidence of injury by time since release from prison, and looking at that incidence of injury separately for 4 groups of people. Those 4 groups being people who have no mental disorder, people with a substance use disorder only, people with a mental illness only, and people with dual diagnosis, both mental illness and a substance use disorder. And the really key finding here, you can see this spike in injury just after release from prison. This is again through prospective linkage with health records. This spike is exclusively in people with dual diagnosis. That's important. Injury includes overdoses because the narrative from WHO, the narrative around preventing overdose after release from prison, has been to focus on people with opioid use disorders. You're probably aware that there's a community transition team. There are community transition teams in BC now supporting people being released from prison, and that service is available for people with opioid use disorders. So these data, if they're similar to what you see in BC, would suggest that that targeting could be tweaked a little bit. It's not people with opioid use disorders per se, who are at increased risk of injury, death and other poor outcomes after release from prison. It's specifically people with co-occurring substance use disorder and mental illness who experience that acute spike. And you can see if you follow people over the longer term, even up to 2 years after release from prison, there continues to be an important gap in the incidence of injury in this group. Injury was by far the leading cause of emergency department presentation and hospitalisation in this group. So just ramming this point home, here's the rate of injury per 1,000 person years over follow-up, and you can see the dotted lines are the rate of drug-related injury after release from prison by time. And what I want to draw your attention to is this dotted line is the rate of drug-related injury after release from prison for people with a dual diagnosis. This is the rate of drug-related injury for all the other groups, including people who only have a substance use disorder. So there is no spike in the rate of drug-related injury for people who just have a substance use disorder. There is a spike exclusively for people with a dual diagnosis. So getting back to the point I made at the beginning about complex needs, complexity, multimorbidity is a key driver of poor outcomes for people who experience incarceration. The other thing I want to point out though is this. This is the rate of all other causes of injury by time since release from prison. So the first thing we've seen here is that spike in drug-related injury is exclusively in the dual diagnosis group. The second point is that after the first 30 days after release from prison, the vast bulk of the burden of injury in all groups of people released from prison is due to non-drug related injury. Now, I don't know whether the same is true in BC. We don't have a fentanyl crisis in Australia at the moment, so this might look very different here, but it really gives one pause to think, are we really focusing a little bit too much on a particular cause of adverse health outcomes? Do we need to think more broadly about the entire burden? And in our study, what were the other causes of injury? So you don't need to be a biostatistician to know that this dot is way above the other dots. So this is the crude incidence rate of external cause injury, again in these four groups. It's intentional self-harm. So what we're seeing is, firstly, a spike in drug-related injury just after release from prison in the dual diagnosis group, and over the longer term, a distinctly elevated rate of self-harm after release from prison, again among the dual diagnosis group. So again, multimorbidity, coordinated multidisciplinary service provision after release from prison is critical to changing health trajectories. Here's some work by Chanel Puljevic looking at another health issue that's sometimes forgotten in this population, which is smoking. We know that in Australia, at least about 3/4 of people who come into prison smoke tobacco. We have smoking bans in most of our jurisdictions. So what Chanel has shown that nevertheless, relapse to smoking after release from prison is very rapid and almost universal. So again, just ramming home this idea that incarceration is not changing health trajectories, it's interrupting health risk behaviours and perhaps temporarily improving some health indicators. So what are we doing about all of this? Here's some work by Emma Thomas where what she looked at is trajectories of psychological distress after release from prison. So what are people's mental health like after their release from prison? So Emma used a thing called group-based trajectory modelling to come up with some different groups of people. People who experience consistently high distress, increasing distress, decreasing distress, and so on. I don't want to focus on that today. What I want to focus on is this. This is among these 5 different trajectory groups that Emma generated. This is the proportion of them who had any contact with mental health services in the year after release from prison. So again, we were able to pick up mental health service contact through prospective linkages with the statewide mental health register. So this is complete coverage of mental health services for this population. And it turns out that even in people who were experiencing consistently very high distress defined by a score above 30 on the K10, which has 0.99 specificity for major mental disorder. So in other words, these people almost certainly had a mental disorder for the entirety of that 12 months. Very, very small proportions had any contact with mental health services, and even those who did only had contact in the first quarter and then it fell off after that. So again, I have no idea whether this is similar to what you would see in BC, but certainly in the jurisdiction where we did this work, it really suggests that there are some really significant issues with engagement and with retention of people with mental health issues after release from prison. We know one of the key reasons for that is this ongoing predictable siloing of mental health and substance use services. People can't get into mental health services because of their substance use disorder. People can't get treatment for their substance use disorder because of their mental health issues. We're really not doing as well as we should. Some work by Amanda Butler, who visited our group in Melbourne last year, looking at emergency department visits. So we were interested to know who visits the emergency department after release from prison, how often and what for. So the key point here is Amanda broke this up into people who had no emergency department visits, who were low frequency users, moderate frequency users, and high frequency. High frequency here defined as 7 or more contacts during the follow-up period in this study. So 3% of our sample were high frequency users of the emergency department. It sounds like a very small proportion. This is looking at what proportion of emergency department contacts each of those groups accounted for. So 3% of people released from prison accounted for 27% of emergency department visits in this cohort. So there's this enormous concentration of high frequency acute and tertiary health service utilisation in people released from prison. Who are these people? Does anyone want to hazard a guess? People with dual diagnosis, exactly. So 77% of mental health visits in the entire cohort, 75% of the substance use visits in the entire cohort were in people who had 3 or more visits in the year after release from prison. So we're seeing this enormous churn through a very expensive tertiary health system in people who are not having their dual diagnosis needs met after release from prison. So we know, and this is a very well established finding that we've just replicated, that people with dual diagnosis are also at increased risk of reincarceration. We've since shown some work by Dominique Andrade showing that there's a dose-response relationship between emergency department contact and reincarceration. In other words, the more times you go to the ED, the more likely you are to go back to prison. Now, I'm not suggesting that emergency physicians are causing people to commit crime, but what I am saying again is that there's potentially an opportunity here to better utilise that contact with the emergency department to address the unmet health needs, including dual diagnosis needs, in a way that not only improves health outcomes for these people, but also potentially reduces reincarceration. It's sort of a win-win if we can do it. How do we do it? Well, we get people into primary care. So some other work by Jesse Young here showing that people who have contact with primary care within 30 days of release from prison are subsequently much more likely to engage with mental health services, more likely to engage with drug and alcohol services, more likely to access appropriate hospital care, and more likely to continue having contact with primary care. So, number one take-home message, get people released from prison into the doctor soon after release from prison. High face validity, low stigma, and it's the funnel into more specialised care. How do we do that? We did a randomised trial in Australia a few years ago now, where with a very low intensity intervention I won't have time to talk about today, we increased contact with primary care at 1, 3 and 6 months after release from prison. So it's easy and cheap to increase contact with primary care after release from prison. We also increased contact with mental health services by 6 months after release from prison. So there are cheap, effective ways of increasing engagement with care for people released from prison. We just did 4 phone calls and look at the dose-response relationship here. For people who got 4 phone calls after release from prison, 58% of them had contact with primary care. People who got 1 phone call, 36% had contact with primary care. So that's a fairly powerful dose-response relationship for such a vulnerable group from some phone calls. So we don't need to spend enormous amounts of money to make a difference for people. The problem is people are already very high frequency users of primary care. Here's some work by Megan Carroll showing that people released from prison in Australia at least use primary care already at about twice the rate of the general population. So people are churning through primary care, typically getting scripts filled, probably not getting the long appointments they need, but already high frequency users of primary care. So it's not simple. And some work by Catherine Snow showing that when we look across all of the health services, so here we're looking at Medicare, pharmaceuticals, ambulance, emergency department, and hospital. When we look at people released from prison, the costs that they incur in Australia are extraordinary. They're much, much higher than we would in the general community. So we estimate in Australia the cost of health services within a year of release from prison is about $258 million each year. So it's very expensive to pick up the pieces after failing to meet the health needs of people who experience incarceration. Where are those costs concentrated again? In the people with the dual diagnosis. So repeated theme here. So just wrapping up, why should we care about this? Really, I'll put this to you as 4 reasons. So next time you're at the pub and your friends say, why are you interested in people released from prison? There's really 4 reasons I put to you. The first is that, as WHO has argued, prisoner health is public health. We're talking about the health of vulnerable members of the community. We're talking about the health of inequalities. The second is that good health is protective against recidivism. So we know there's growing evidence that improving the health of people released from prison it reduces their risk of going back to prison. So that's a win-win. We know that poor health outcomes after release from prison are costly. It's expensive to do a bad job. And of course there's the human rights and health inequalities argument, and because I'm over time, I'm going to skip through WHO's various advocacy around this. Suffice to say that WHO has very clearly articulated on multiple occasions that addressing the health needs of people who experience incarceration is a critical part of addressing health inequalities at the population level, including in your region, including in the Americas. So you may be aware that PAHO recently released a preliminary report from a high-level commission on equity and health inequalities led by Michael Marmot, who Ruth is good buddies with now after a meeting in Toronto. And one of the things that they've said, and this requires a lot of fleshing out, is that mass incarceration is an important determinant of health. So again, this is about health inequalities at the population level. And I should stop there. Thank you.
All right, so we have some time for questions. And do we have anybody online? Questions?
Thanks for that really interesting. Sorry. That was a really interesting presentation. Thank you for that. I was struck by your data comparing the Indigenous youth, females and males, with non-Indigenous females and males. And I see some parallels to our situation here. So we did analysis looking at the entire population of BC injury rates for Indigenous and non-Indigenous populations. And when you look at injury rates in general, males are way, way, way higher on every cause of injury than females, except for Indigenous people, where you see that females are higher, particularly for the intentional injuries, the suicides and the violence. And I saw the same patterns in your data. And so it just really, really struck me how big a priority this needs to be for this population.
Thank you for that. I completely agree. So obviously, one thing that Canada and Australia share is massive overrepresentation of Indigenous peoples in custody. In Australia, Indigenous people are 13 times more likely to be in prison, 24 times more likely to be in youth detention. So this is really an important part of addressing the gap in health outcomes for Indigenous people in both of our countries. What do we do about it is the tricky part. I think firstly, reducing the overrepresentation of Indigenous peoples in custody is a start. One of the things that I think in Australia we're starting to recognise is that that's not enough though. And we're not just talking about diverting from, we need to start thinking about what we're diverting people to. Because one of the reasons that people are experiencing contact with the criminal justice system is because of unmet needs. How do we address those needs? That's a whole complex narrative as well. It's certainly, we need to start listening to what Indigenous communities to sort that out.
Great, hi, Stuart, Mark Tyndall here. That was a really excellent overview of things. One thing occurred to me though is that should we be advocating strong for better prison health when probably most of the problems happen before people get to prison, or the trajectory already starts? So all the epidemiology you showed us, the starting point is incarceration. And is there, you know, how do we position this issue prior to incarceration? And then a second quick question is that, is there, some of this could be stratified by reason for incarceration. So if you dump everybody who's incarcerated into your analysis, it might turn out different than if it was people there for drug-related causes, for instance.
Thanks, Mark. I might respond to those in reverse order. So the categorising people by the reason they're there, I think, is really important. It's difficult to do because often, you know, the correctional records don't give you quite the nuance that you want. I think a reasonable proxy for those low-level drug and acquisitive crimes is the short sentences, and we know that people who are churning through prisons rapidly on short sentences have worse outcomes in multiple ways. And it really goes to your point about reducing incarceration in the first place. Going to your other point, though, about should we be thinking upstream, you know, the first answer is absolutely yes. The second part of that, I think, is that we need to be careful not to frame it as an either-or narrative. So clearly we need to be stopping and reducing incarceration, going upstream and identifying the drivers of incarceration. But at the same time, that shouldn't preclude ensuring that when people do end up in the system, that we maximise the quality of care they receive, not only while they're in there, but seizing that unfortunate opportunity to initiate new trajectories. And I think we're really doing a bad job of that at the moment. And I think it's really important that we don't frame that as an either-or narrative.
Dave Patrick, thanks very much. I just wanted to stop Ruth and say how far this has come in less than a decade since she started dropping by me on this, so it's quite incredible. And Stuart, thank you. Either of you can sort of address this question. You've made a very good case for considering the whole prison population, this endemics thing, and sort of a total sort of primary care kind of model. And at the same time, we're looking at the relative importance of prisons as places in which we have transmission of a now curable hepatitis C virus epidemic. So I'm wondering how you put this care for the total prisoner together with this more vertical concept, which I think is actually taking flight in Queensland around micro-elimination in facilities.
Ruth's an actual doctor, so I thought she might want to respond to that. Look, you know, good point. I guess I don't see them necessarily in conflict at all. I mean, we have whole populations. If we think about what we do in the community, you know, community level health promotion and surveillance and response to health needs in no way preclude our efforts to focus on particular health conditions, hepatitis C, HIV, mental disorder, substance dependence, whatever it may be. And I think the same framing is appropriate in prison settings. It's just like a microcosm of what we have in the general community, where the prevalence of every health condition you can think of is amplified, and the co-occurrence of those health conditions is amplified. But the same basic principles, I suppose, apply, except to say that the need for coordination and multidisciplinary care is proportionately greater. I hope that's not a superficial response.
We have an online and listening to rounds. Some very sad statistics that people exposed to the criminal justice system have shortened survival, much of which are due to overdose and suicide. How do we provide continuity of care and long-term supports following incarceration?
Complex question. The first answer is listening to what WHO has suggested and what BC has now done, which is to have care and custody provided by the same Ministry responsible for healthcare in the community. That's a key sensible way of achieving continuity of care. There's a lot of there's a lot of detail in that. There are some nice randomised trials now thinking about how we do that specifically for people released from prison. A key part of it, again, coming back to this notion of multimorbidity, is care coordination. So we know from some studies that we've done in the US and Australia, that, and some work in the UK as well, that in reach from a case manager whose job is not to deliver care, but to coordinate care is an important part of that. The other part of this, given the massive impact of those social and structural determinants of health for this really marginalised group of people is not just providing health care, but helping people to navigate the systems that they need to create an environment in which they can experience health. And again, the evidence there suggests that peers are a really important part of that. There are some really nice examples. In fact, the transitions clinics in the US is one where a care coordinator who's a peer, who's employed, properly paid, trained to provide care coordination, pairs up with a physician who's providing health care. So those sorts of models, which are very similar in some ways to the CTTs that are happening in BC, are probably a promising start.
I wonder if you can help me to understand the causality here. So you've mentioned you are not sure what's causal, and that perhaps imprisonment sort of interrupts this risky behavior. So as a determinant of health, is imprisonment itself a marker of high risk, or is it a cause? Is it a beneficial or detrimental effect?
We could do a whole seminar on that one. The short answer is that the evidence is incredibly weak. I think there's enough evidence to say that certainly incarceration is a marker for risk, and probably that's the main reason why we see such poor health outcomes, at least in high-income countries. But there's also sufficient evidence to say that incarceration has some causal contribution to some adverse outcomes. The obvious one being opioid overdose, fatal and non-fatal immediately after release from custody. We know that reduced opioid tolerance in prison increases people's risk of overdose after release from prison. So it's a combination of those two things. What do we do about that? We do want to reduce incarceration, but going to your point, that's why we need to think not just about reducing incarceration, but also finding better ways to address people's health needs so that the risk factors that lead to those deaths are changed.
Unfortunately, we have reached the end of our session, and that was wonderful. Thank you. Please join me in thanking Stuart Kinner.